Good afternoon and welcome to the Immunization Schedule Updates webinar, the first session of the 2024 immunization updates. A couple of housekeeping items. You will receive an email in about a week with a link to an evaluation. Please complete the evaluation for your education credits, which will follow about 2 weeks later. A reminder, each attendee must register individually to be eligible for credits and must attend the entire session. The slides are posted on the materials page, and we'll post a recording of this webinar and the other sessions on our events page. You'll find the links to these two pages in the chat box, plus my email address for follow-up questions. Please feel free to type in a question to the Q&A question box, not the chat. The moderator for today's session is Lori Courtney, Immunization Nurse Manager and Perinatal Hepatitis B Coordinator here at the Massachusetts Department of Public Health. Lori?
Thank you, Ted. Good afternoon, everybody. Before we begin today, we wanted to take an opportunity to wish our nurse colleagues on the webinar a very happy Nurses Week. And now it is my very great pleasure to introduce Dr. Angela Fowler. Angela is a primary care physician and is the Associate Medical Director for Vaccine Preventable Diseases at the Massachusetts Department of Public Health. Dr. Fowler will be presenting this year's immunization schedule update. Now over to you, Angela.
Thank you, Lori, and happy Nurses Week to everyone. Hello, everyone. I'm very happy to welcome you to the very first webinar in our annual immunization update webinar series. My name is Angela Fowler, and I will be presenting updates to the adult and childhood vaccine schedules. The planning members and moderators of this session have no relevant relationships to disclose, and I have no relevant relationships to disclose. I want to start out by thanking everyone for your attendance today, and thank you for being a part of the community of vaccinators. Safe and effective vaccines are critically important for the health of the public, and I think this quote expresses this very well. The impact of vaccination on the health of the world's people is hard to exaggerate. With the exception of safe water, no other modality has had such a major effect on mortality reduction and population growth. So today, what we'd like to cover is an overview of how the vaccine schedule is formatted, important formatting updates and changes to the vaccine schedules, and changes in vaccine recommendations. So the vaccine schedules are important and informative documents. They represent the current approved policy of the Advisory Committee on Immunization Practices, or the ACIP. They're updated every year. ACIP recommendations can be complex and challenging to implement. The purpose of the immunization schedule is to consolidate and summarize updates to ACIP recommendations so that clinicians can implement these recommendations. There are two separate schedules, the child and adolescent schedule and the adult schedule. So looking at the format of the schedule, on the screen is the child and adolescent immunization schedule, but the adult schedule is formatted very similarly. The first page that we're looking at is the cover page. On the left side of the cover page is a table with a list of products included in the schedule, with the generic names, the abbreviations, and the trade names. Also on the cover page, you'll find the website and QR code necessary to access the schedule online. And there are also links to other helpful information, including the CDC's Vaccine Adverse Event Reporting System, otherwise known as VAERS, if you need to report a clinically significant vaccine-associated adverse event. The box in the upper right corner of the cover page provides basic instructions on how to use the schedule to systematically identify vaccine needs. So this is a larger view of the instructions inside of that box on the cover page. Providers are advised that the entire schedule should be used to assess vaccine needs. Table 1 allows providers to view vaccine recommendations by age. Table 2 shows recommendations for children who may have missed vaccines, a catch-up schedule. Table 3 allows us to view vaccine recommendations by medical indication. The vaccine notes provide considerations and discussion for special situations. And the appendix has contraindications and precautions for vaccines. And I want to point out that the addendum is a new section added to the schedule this year. The addendum section summarizes any changes or updates to the ACIP recommendations that occur after the schedule was voted on and approved by the ACIP in October of 2023. The CDC wants to more quickly update the schedule. So this year, actually, it publishes schedules earlier than before, and it's providing this addenda with regular updates. And this is helpful because the timing of the adding of vaccines to the schedules can impact insurance coverage and payment for vaccines. So we'll cover the updates and some of the recommendations in the schedule. We'll start with the pediatric schedule, then move on to the adult schedule, and then finally discuss recommendations that have been updated in both the pediatric and adult schedule. So we'll start with the pediatric schedule. And we'll start with PCV 20. And I will take this opportunity to mention that after being voted upon by the ACIP, all of the recommendations included in both the pediatric and adult schedule are published in the Morbidity and Mortality Weekly Report, or the MMWR. This is what you can see on the screen. And this is where you can find more detail about the recommendations. So PCV 20 is a new addition to the childhood schedule, and it can be found on the table on the cover page. PCV 20 is targeted against the bacteria Streptococcus pneumoniae. This bacteria is classified into serotypes based on the capsular polysaccharide, which are used as vaccine antigen targets. This pathogen continues to be a common bacterial cause of both pneumonia and otitis media in children, and also more serious diseases such as invasive diseases such as bacteremia and meningitis. PCV is abbreviation for pneumococcal conjugated vaccine. Over the years, vaccine makers have been able to increase the number of serotypes covered. The newest PCV 20 covers 20 serotypes, 5 more than PCV 15. So last year, PCV 20 was added to the pediatric schedule, and it was already on the adult schedule. The ACIP recommended PCV 20 for children in situations for routine use, catch-up vaccination, and also for children who have risk condition. I will mention that on the CDC schedule, PCV 15 and PCV 20 are recommended interchangeably. But in Massachusetts, things are a little bit different. September of last year, the Massachusetts Vaccine Purchasing Advisory Council voted to include PCV 20 as the only PCV option for the Massachusetts Vaccine for Children program. Committee members, when voting, considered the extended serotype coverage and the simpler dosing regimen for children with chronic medical conditions with PCV 20 compared with PCV 15. So looking at Table 1, vaccines by age, we see the routine recommendations, the routine ages recommended for vaccination with PCV 20 are depicted in the yellow bars. So you would give PCV 20 to infants in a series of 4 doses at 2 months, 4 months, 6 months, and 12 through 15 months. You also see on this table the ages where catch-up vaccination is recommended for healthy children, and that's depicted in green, the green bar. And then finally, you'll see where the ages where catch-up vaccination is recommended for children with risk conditions, and that's indicated by the purple bar. Table 2, which is catch-up recommendations, has advice about spells out the advice for catch-up vaccination. And it's recommended that healthy children up to age 5 with incomplete PCV vaccinations should complete the series, and children up to age 6 with underlying health conditions should complete the series. In Table 3, vaccines by medical indication, the brown fill under most of the conditions listed at the top means that we should provide age-appropriate vaccination, but that additional doses may be needed, and to see the notes for more detail. When we move to the notes section, we're advised that for healthy children, PCV20 is not indicated if they've received 4 doses of PCV13 or PCV15. We also find in the notes section that there is guidance about special situations, including medical conditions. So you can see there's advice provided about when and which additional doses might be needed. And you can see that in the text there, the recommendations are quite complicated. So I would like you to know about, there's an app that the CDC publishes called Pneumorex, which is downloadable free, and it is really helpful in allowing clinicians to sort out complicated recommendations in more complicated situations. So from the recommendations for PCV20, from that, you can see how the whole schedule should be used when assessing vaccine needs. We'll move on to the next project, the next product added to the childhood schedule, which is nirsevimab. We find nirsevimab on the cover page, and actually a new category has been added for nirsevimab, which is not a vaccine technically, but a monoclonal antibody. So the monoclonal antibody section was added. Respiratory syncytial virus, or RSV, is a significant public health concern for children. It's one of the most common causes of childhood illness and is the most common cause of hospitalization of infants. It causes seasonal outbreaks of respiratory illness, and it, as you can see from the graphic there, it causes significant medical visits and is estimated to cause between 100 and 300 deaths of children per year. Nirsevimab is a new product designed to protect infants from RSV. It's technically not a vaccine. It doesn't stimulate the immune system. It's a human recombinant monoclonal antibody with activity against RSV, what we call passive immunization. The monoclonal antibody binds to the RSV fusion protein, the F protein, and that's the site at which the virus would attach and fuse with a human cell. So on table 1, we can find the routine age indication for nirsevimab in the yellow bars. And so for nirsevimab, infants less than 8 months of age born during or entering their first RSV season are recommended to receive 1 dose of nirsevimab. So indicated in the purple bars, we see that high-risk children can receive a dose between 8 and 19 months. Moving into the second RSV season. On table 2, we find that certain high-risk children may receive an additional dose or may receive a dose during their second RSV season. When we look at the notes section, there's a detailed explanation of the special risk situations and conditions that may warrant a dose at 8 to 19 months. And it also discusses timing during the year, because this is a vaccine, or this is a immunization product that is seasonally administered. So we'll now move on to the adult schedule. The adult schedule is very similar to the children's schedule. On the cover page, there's a table containing the vaccines covered in the schedule, and there's also a box with instructions about how to use the schedule. And the only difference in how to use the schedule is that the adult schedule does not have a table for catch-up vaccination. We'll start with the new RSV vaccines for adults. And we can find these vaccines on the cover page table, a Rexv and a Brisvo. So we discussed that RSV infection is very impactful for the young pediatric population. This virus is also impactful in the older adult population. RSV causes substantial morbidity in the older population, causes a large number of medical encounters and hospitalization, and is estimated to lead to 6,000 to 10,000 deaths in adults over 65 per year. So now we have two vaccines that can help older adults, protect older adults from RSV. And this has been something that has been a public health quest for more than 50 years. The two new vaccines are a Rexv and a Brisvo, and they're recommended for use in adults 60 years of age and older with shared clinical decision-making with a provider or clinician. Both of these vaccines work by triggering antibodies against the virus F protein, again, that interferes with the virus's ability to fuse and infect human cells. On table 1, we can find these vaccines on the table of the vaccine schedule by age for 2 indications. So there's an indication for older adults 60 years and older who may receive a single dose of RSV vaccine using shared clinical decision-making, which is denoted in the blue box. And then there's another indication for pregnant people, also indicated there in the purple, but we'll come back to that in just a minute. On table 2, the vaccines by medical condition, you see the blue bar indicating shared clinical decision-making recommendation under most of the conditions listed at the top, and to see the notes for more details about that. So in the notes, it does advise that persons most likely to benefit from vaccination are those considered to be at increased risk for severe disease from RSV. The notes section also has a list of chronic underlying medical conditions associated with increased risk of severe RSV disease that clinicians can consider when they're discussing this vaccines, the risks and benefits with their patients. And so just coming back, I mentioned earlier that in addition to older adults, pregnant people are recommended to receive the Brisvo vaccine, one of the RSV vaccines. And that is denoted by purple, which is notes that if a person has the additional risk factor of pregnancy, then the vaccine is recommended. So a Brisvo is administered to the mother when they're pregnant to prevent lower respiratory tract infection from RSV in newborn infants. The maternal vaccine is recommended for pregnant people during the 32 to 36 weeks of gestation with seasonal administration, administered from September through January. The Brisvo vaccine that we use for maternal vaccination is the same formula of the Brisvo vaccine that's recommended for adults age 60 and older with shared decision-making. However, it's important to note that a Rexv, which is the other RSV vaccine that's indicated for older adults, cannot be used as a maternal vaccine. So a Brisvo as a maternal vaccine is actually on both the childhood and also the adult vaccination schedule. So I'll bring you to this very nice summary table. It's been a really important year for protection against severe RSV disease. We now have great products that help protect vulnerable populations, such as young infants and older adults. So looking at this summary chart, we see that adults 60 and older can receive the RSV vaccine, and there are two options, Abrysvo and Arexvy, and that's recommended on shared clinical decision-making, and they're going to be people who have certain risk conditions that are going to be benefit most from the vaccine because they have higher risk for RSV. For babies, we have two options. We have the monoclonal antibody, the nirsevimab, that is given to the baby seasonally. And we also have an RSV vaccine that can be given to the mother before the baby is born to protect the baby from RSV disease. So we've covered the pediatric update, so we'll move on to the adult updates. So we'll move on to updates that affect both the pediatric and the adult schedule. So we already did talk about Abrysvo, which is the maternal indication is on both the pediatric and adult schedules. And now we'll talk about the vaccines listed here. So we'll start with the meningococcal vaccine. Meningococcal disease is a serious and potentially life-threatening infection caused by the bacterium Neisseria meningitidis. Neisseria meningitidis can be classified into 12 serogroups based on its capsular polysaccharide. Serogroups A, B, C, W, X, and Y are the primary causes of meningococcal disease worldwide. We do have three types of meningococcal vaccines. We have quadrivalent vaccines. There are two options available, and these vaccines cover serotypes, four serotypes, A, C, W, and Y. We have two monovalent vaccines, which cover serogroup B. And we have the new pentavalent vaccine, which covers the serogroup coverage of the quadrivalent vaccine and the monovalent vaccine. So the pentavalent vaccine covers serogroups A, B, C, W, and Y. And the trade name is Pembrea. So the meningococcal vaccine recommendations have not changed. So ACIP did not change the recommendations, but rather they've added this new meningococcal vaccine to the schedule. So the recommendations that ACIP still recommends that the quadrivalent meningococcal vaccine, the MenACWY, is administered to adolescents at age 11 to 12 years with a booster dose at age 16. The monovalent meningococcal B vaccination is recommended with shared clinical decision-making, and the doses are administered in later adolescence. And in addition to these age indications, people with medical conditions or medical treatments that put them at higher risk for meningococcal disease are also advised to get these vaccines. So in the interest of time, I'm not going to show you where these vaccines are on the schedule. I'll just update what the recommendations are from the ACIP, but we went through kind of how to use the schedule and the other examples. So the ACIP recommends that we can use Pembrea, the pentavalent meningococcal vaccine, as an option when both the quadrivalent, the MenACWY, and the monovalent, MenB, are indicated at the same visit, according to the existing guidelines. So that might occur. You might use Pembrea if you have a healthy 16, early or later adolescent person who chooses to receive the MenB vaccine and also needs the quadrivalent vaccine at the same time. And this also may be used by people who are older than 10 years of age and are at increased risk for meningococcal disease because of health conditions, who are due to receive both the quadrivalent and monovalent vaccine. You could administer the pentavalent vaccine instead and just combine those two injections into one injection. Moving on to the polio updates. So polio is a highly contagious disease caused by 3 serotypes of the polio virus. Infection with the virus results in a clinical spectrum of illness. It can be asymptomatic, but also can manifest as very serious disease, such as aseptic meningitis, paralytic disease, and death. Paralytic polio decreased rapidly in the US after introduction of the polio vaccine, and by 1994, polio had been eliminated from the Americas. But in July of 2022, a case of paralytic polio was confirmed in an unvaccinated adult living in New York State. And subsequent testing of wastewater systems detected polio virus in a total of 5 New York counties, including New York City. And what this demonstrated is that even though polio has been eliminated from the Americas, US citizens remain at risk of polio virus that's imported or brought in from other countries. And this will be a risk as long as there's ongoing transmission of polio virus globally. So unvaccinated and incompletely vaccinated adults remain susceptible to paralytic polio. So for polio vaccine, again, the standard vaccination has not changed. The standard vaccination is in childhood with a 3+1, with 3 of the vaccines administered during infancy, and then a booster dose at age 4 through 6 years of age. And previously, prior to the update, only the catch-up vaccination recommendation was only up to 17 years of age. But the ACIP update this past year was that adolescents and adults age 18 years and older who are known or suspected to be unvaccinated or incompletely vaccinated against polio should be caught up and vaccinated, complete a primary vaccination series with IPV or an activated polio vaccine. The other part of that is that adolescents and adults age 18 years and older who are already vaccinated, but at increased risk of polio exposure, perhaps through travel or occupation, may receive 1 lifetime booster, may receive another dose of IPV because of their risk factor. Moving on to COVID-19. So we're all familiar with COVID-19. The clinical presentation of COVID-19 varies from asymptomatic to critical illness. It's not really a clear seasonal pattern as yet. The burden of COVID-19 varies by age and underlying status, with those who are older and have multiple underlying conditions having the highest risk of severe outcomes due to COVID. The COVID burden currently is much lower than at previous points in the pandemic. However, it's still out there. People are still getting sick and hospitalized, and there are deaths that occur from COVID still. The monovalent updated vaccines do increase the immune response against the currently circulating variants in the communities. So the ACIP recommended that everybody aged 5 years and older should get 1 dose of the updated 2023-2024 COVID vaccine to protect against serious illness from COVID-19. Children aged 6 months to 4 years need multiple doses of COVID-19 vaccines to be up to date. And this series should include at least 1 dose of the updated 2023-2024 COVID-19 vaccine. We have 3 available vaccines in the United States, 2 mRNA vaccines from Pfizer and Moderna, and 1 protein subunit vaccine from Novavax. So this COVID vaccine is an example of when the addendum provides useful information. So after the vaccine schedule had been approved by the ACIP in October 2023, in February 2024, the ACIP recommended an additional dose for persons 65 years and older. So the recommendation is that all persons age 65 and older should receive 2 of the updated 2023-2024 COVID-19 vaccines. And so that's a good example of how the addenda will be used to keep providers updated on recommendations as they're approved by ACIP. We'll talk about influenza. Influenza causes annual outbreaks of respiratory illness in all age groups. And so routine annual influenza vaccinations for all persons 6 months and older who don't have contraindications has been recommended by the CDC and the ACIP since 2010. The update to the influenza vaccines are that in 2024-2025, the upcoming flu season, the flu vaccines will be trivalent, and they were previously quadrivalent. The trivalent vaccines will omit the B Yamagata strain because it's no longer actively circulating. So that is an update, a major update. And then the other update that the ACIP recommended last year is that people with egg allergy may receive any vaccine, any flu vaccine, egg-based or not, that is otherwise appropriate for their age and health status, and additional safety measures are no longer recommended. So even if people are severely allergic to eggs, there's no recommendation for enhanced safety measures. We'll move to Mpox. So Mpox, we've been experiencing a global outbreak of Mpox, which has been called monkeypox as well. It's caused by infection with the Mpox virus, which is an orthopox virus in the same family. The smallpox virus is in the same family. This current outbreak has affected mostly men, 90% men, and 90% of affected are gay, bisexual, and other men who have sex with men. 40% of those affected by the current Mpox outbreak are living with HIV, and there's a high level of concurrent STI diagnosed when people present with Mpox. The diagnostic symptom and sign of Mpox is the rash, and you can see the rash, very characteristic rash depicted in some of the pictures to the right. And so we can see on the graph to the left, the peak case counts for the Mpox vaccination occurred in summer of 2022 and have kind of dropped off. But although case counts have dropped since the peak of the outbreak, these cases are still occurring. And the CDC recently released data that more than 570 cases of Mpox have been detected in the US so far in this year, 2024. And this is nearly double the number seen by this time last year. So we still need to be vaccinating and protecting people who are at risk for Mpox. So we do have an effective vaccine to protect people from Mpox. It's called Jynneos. It's the Jynneos vaccine. This vaccine was approved by the FDA for the prevention of smallpox and Mpox. And it's an attenuated, non-replicating form of the live Vaccinia virus. The ACIP recommended Jynneos based on a person's risk. And they recommended that people age 18 years of age or older at increased risk of Mpox should receive the vaccine. And they classify increased risk as persons who are gay, bisexual, and other men who have sex with men, transgender or non-binary people who in the past 6 months have had at least one sexually transmitted disease, more than one sex partner, sex at a commercial sex venue, sex in association with a large public event, and persons who are sexual contacts of the persons described above. This is currently a vaccine that's licensed for people age 18 years and above. Currently, there's an NIH trial ongoing to evaluate the safety and efficacy for people who are younger. So I'll include kind of a bonus vaccine. This is not a vaccine that's on the schedules. It's a travel vaccine, so it's not scheduled, but I think it's good fun to talk about because it's a new vaccine against chikungunya, and we've not had a licensed vaccine against chikungunya before. So chikungunya is a mosquito-borne viral illness, and is typically endemic to tropical and subtropical regions. It periodically causes large outbreaks, and during those large outbreaks, there's often high attack rates. There's moderate disease burden among U.S. travelers with 100 to 200 cases reported annually. And there's a substantially higher risk of infection if a person travels to an area during an outbreak. So chikungunya, the clinical features of this condition is it's a febrile illness, and it's characterized by severe joint aches, which can be debilitating. This condition can resolve, but even after resolution of the infection, people, a substantial minority, I believe up to a third of people who are affected by chikungunya can have persistent severe joint pain, which can be quite debilitating. The joint symptoms involve multiple joints, most commonly hands and feet. Other symptoms include headache, rash, myalgia, anorexia, and there's no specific antiviral treatment available. So we did just recently have a vaccine against chikungunya license. The vaccine name is IXCHIQ, and it's can be used in individuals 18 years and older, indicated for individuals at increased risk of exposure to chikungunya virus. It's a live virus vaccine, so it's contraindicated in immunocompromised individuals. So the ACIP recommended the chikungunya vaccine for persons 18 years and above who are traveling to a country or territory where there's an outbreak of chikungunya. And in addition, they recommended that chikungunya vaccine may be considered for people traveling to a country or territory without an outbreak, but where places where there have been outbreaks in the past 5 years. And particularly people who are age 65 and older and with underlying medical conditions who are likely to have at least moderate exposure to mosquitoes, and also people who are staying for a cumulative period of 6 months or more. So I want to end by just advising you of some resources that we have. The vaccine schedules and recommendations are just getting more complicated over time. More vaccines, more recommendations, but there are resources that can help us. So I want to point out, I did point out the Pneumovax, the Pneumorex Vax Advisor for pneumococcal vaccine recommendations that can be quite helpful in complicated situations. You can also, there's also an app for the vaccine schedules themselves, so you can have them on your phone to access them very easily. And another great vaccinator resource is immunize.org. They're a great organization that has a lot of information and resources available for clinicians and patients online. So they have the information sheets and about vaccinations or vaccine information sheets, the viz statements in multiple languages available, a number of a great amount of good information on that website too. So that's another great resource. So I will end there, and we can take questions at this time.
Thank you so much for that wonderful presentation, Angela. And we do have time for some Q&A. We have several really great questions that have come in. And a reminder, if you have questions, please enter them into the Q&A box, not into the chat box. So let's start with some of the ones that have come in. Angela, somebody is asking related to RSV. I thought this was an interesting question. You know, you said that pregnant women might get vaccinated and infants might get a monoclonal antibody. Why aren't people over 60 years old who live with infant children recommended to get the RSV for that specific category? You know, we know that over 60, if you're at risk for RSV, you're getting it to protect yourself. Why isn't someone over 60 advised to get it to protect the infant?
I think that's a great question. I think it's because it hasn't been studied. That usage hasn't been studied and shown to be effective. So that's not an indication. Having an infant around is not a specific indication for an RSV vaccine for an adult or older adult. So that it hasn't been studied. Maybe studies in the future might look at that, but for now, it's the products that we have are proven or have studies to show their efficacy in protecting infants.
Also, right now, when pregnant women are vaccinated, it's not as much to protect the pregnant woman from contracting it, but to give passive antibody to the infant. So really, whether the pregnant person is getting vaccinated, it's for protection of the baby. It's actually for the passive immunity. And then, of course, if the baby is getting the monoclonal antibody at birth, it's direct immunity, but not cocooning the infant like we do with Tdap.
That's correct. That's very correct. The maternal vaccination is not a vaccine, as you stated, to protect the mother. It's to provide antigen to the mother so that they produce antibody in their body, which is passively kind of transferred to the infant.
And we had a couple good questions related to MenB and the pentavalent meningococcal vaccine. And a couple people have pointed out that we know that MenB has sort of a shorter length of effectiveness, and also that because of that, MenB maybe should be administered on the later side of adolescence and under shared clinical decision making, whereas the ACWI right now is at age 16. So the questions are sort of, why would we give the pentavalent to a healthy 16-year-old? Or should we stick with ACWI at 16 and then B at 18 before college? Sort of, what are the indications for the pentavalent?
Yeah, I think it is. That's an interesting question as well. I think that one of the things to consider is that when the pentavalent vaccine was licensed by the FDA, the ACIP has to consider that vaccine and figure out how it's added to the schedule. However, they weren't at that time ready to change the recommendations. So we have this new vaccine, but they aren't ready to change the existing recommendations just yet. That is coming up. So the ACIP is actively looking into changing the recommendations to see whether or not the current recommendations still make the most sense in as far as vaccinating adolescents on a routine basis. So what the ACIP is recommending is still following their previous guidance, basically. So they're at this point, they're still recommending that the MinACWY be administered to adolescents at age 11 to 12 and 16, and that B is shared clinical decision making. And and whether or not you give that Min B at 16 or closer to maybe 18, when a adolescent may be moving to a congregate setting such as college or military, I think that's a clinical decision. So you have that option to separate the MinACWY and administer that on the schedule. And Min B is shared clinical decision making. So it's not unreasonable to push that one closer to a little bit older, when there might be a bit more risk for Min B. And as you mentioned, the Min B protection may not be as durable as the Min ACWY. So we will be getting, and the pentavalent vaccine is something, again, you can use it if you're in a situation where you have someone who needs both of those vaccines on the same day. We will be getting updated guidance around meningococcal vaccines. The ACIP wanted to get one more year of epidemiology, post-pandemic epidemiology, to really try to figure out the timing. And so I think we're going to get more information and more guidance about how we can, about the schedule, and also how we can fit the pentavalent vaccine into the schedule.
Thank you. And I think you said a very important point that I want to reiterate, that for most combination vaccines, the guidance is to go ahead and administer it whenever any of the antigens is needed. But with the pentavalent meningococcal vaccine, they're very explicit that it should only be used in instances where both the ACWY and the B vaccine are both indicated. So very different guidelines. A follow-up question is, will the Penbrea be available in Massachusetts through the Pediatric Universal Program?
Not just yet. Not just yet. It can be purchased privately, but it's not yet available on the Massachusetts Pediatric Vaccine for Children program.
And somebody asked about, do we expect to have a standing order for the pentavalent? Is it expected to have a standing order template? And I'll just say that standing order templates are available on immunize.org. And in general, there are not standing orders for anything that includes something that is administered under a shared clinical decision-making situation, because the idea of standing orders and shared clinical decision-making are kind of on opposite ends of the spectrum. If you're supposed to be looking and deciding clinically if it's warranted, it doesn't really, it's not something you'd use a standing order form. Okay, there was a question, although you didn't specifically cover it today, somebody wanted to know, let's see. Their PD practice still has some non-expired PCV 13 left. Can it still be used?
So technically, yes. What's on the current schedule is PCV 15 and PCV 20. The guidance is that PCV 13 can be used if there are no other options, no available options. So it's not, I wouldn't consider it the optimal or the first line, but it can be used if there's nothing else available.
Okay. And will there be an updated COVID-19 vaccine this fall?
Yes, there will be. And so the FDA is meeting in about a week to discuss the strains and the for the new vaccine upcoming. And it's the plan of the ACIP and the FDA to try to move this process a little bit earlier in the year. So deciding on the strains, deciding about the vaccine earlier in the summer to kind of give pharmaceutical companies time to manufacture and get it available for early in the fall. So yes, there will be. And we'll be looking out for new recommendations.
And if we have a patient between 6 months and 11 months who is traveling internationally, I know we should encourage a dose of measles vaccine be given. Is a dose given to someone under 12 months old counted as a part of the regular 2-dose series?
So good question. No, it's not counted. It's important, as you know, that there's a global outbreak or uptick in cases of measles, and we're seeing increased cases of measles in the United States. We want people to be protected against measles, and a population of people who aren't are the under 1 population who have not yet gotten their scheduled MMR vaccine. So the current recommendations are that children between 6 months and 11 months who haven't yet gotten they wouldn't have gotten their scheduled MMR vaccine should get a travel dose, a dose prior to travel, a dose of MMR prior to travel. But that dose is really only to protect them from travel. They still need to get the 2 scheduled doses at 12 to 15 months and also at 4 to 6 years. So it's important to protect children going abroad because there's currently a great risk of exposure in foreign countries, but it doesn't count towards the scheduled dose.
And somebody with really sharp eyes pointed out that there may be a typo on slide 22. We will be sure to look at the slide and correct it in the final version that is posted. So we'll look at that. Thank you to that person with the sharp eyes. Somebody points out that they have multiple patients who were vaccinated this fall for influenza, who then did get flu around February, more than 90 days after vaccination. They're wondering if we know yet how effective this year's flu vaccine was. Was it a good match? And is there a concern about duration of efficacy similar to COVID-19 vaccines? And is there any consideration for revaccinating individuals in the second half of the season?
So no, there's no consideration being given to vaccinating people a second time during the same season. I did see presentation on the efficacy of the influenza vaccine this past season, and the efficacy varies by age group and against different strains, but it looked like it was between 40 and 60% vaccine efficacy, which seems to be about where it usually will fall. So I think that it was kind of a typical season. I don't think there was a big mismatch in strains with what was seen, and the vaccine efficacy I think was considered good. It is true that it's not 100% vaccine efficacy. I do think that people who, even if the vaccine efficacy isn't 100% in preventing influenza, people who are vaccinated and do actually become ill tend to have less severe illness, I think. So that's how I would answer. But I definitely don't I think we're trying to get people to get their first dose of a flu vaccine, which we think is very, very, very important. But no second dose is recommended at this time.
And somebody would like to know whether RSV vaccine, well, they're asking if it should be given all year long or there's a cutoff. When I first looked at this question, I thought specifically they were talking about pregnant women and infants, but perhaps they're asking about older adults. So would you want to answer first, or if you don't have every fact in your brain, I happen to pull up the immunization schedule, because I don't want to put words in your mouth, but I do know that the vaccination for pregnant women and infants is not year-round. There's a definite window.
Correct. Right, that's a seasonal vaccine. For the pregnancy indication, it's September to January, end of January. So that we would stop vaccinating in the last day in January. But for the indication for older adults, there's not a seasonal recommendation necessary. There's a one-time dose. At this time, it's just recommended that people who choose to be vaccinated, who are older adults, will just get one dose one time. And there's not necessarily a seasonal recommendation.
And for the monoclonal antibodies for newborns, I believe that's through the end of March, at least in this area of the country. There are other areas of the country that is a bit longer, different timelines. And we have time for one more question. And I'll just say, somebody asks, where can we get the laminated immunization schedules that we used to receive at conferences? And I could say that they were handed out at the last conference, and we do try to hand them out at our in-person conferences. The laminated schedules can be ordered from immunize.org. They do cost money. Of course, you can always print them off in color from the CDC website, or print them in on cardstock for a little more durability. And if anyone's going to the MAPHN conference that will be taking place tomorrow, the schedules will be available there also. And if we didn't get to your question, just send your questions into Ted or Angelo, whose emails are in the chat.
Thank you again for joining us, and we hope you enjoyed Dr. Fowler's presentation with Lori Courtney assisting us as moderator. Please feel free to follow up with us for any additional questions. As Lori mentioned, you'll find our email addresses in the chat box, along with links to the materials page where you will find the slides, and our events page where a recording of this webinar will be posted. Thank you and have a great day.